Sjogren syndrome, it is an autoimmune disorder. It is a chronic inflammatory disease that predominantly affects salivary, lacrimal and other exocrine glands. It is described by Hendrik Sjogren in 1933. So predominantly affect middle-aged and elderly women. It is very important. Middle-aged and elderly women are predominantly affect. And what are the types of Sjogren syndrome? It has two types: primary Sjogren syndrome and secondary Sjogren syndrome. Primary Sjogren syndrome is also called as Sicca syndrome. It consists of dry eyes, that is xerophthalmia, and dry mouth, that is xerostomia. And secondary Sjogren syndrome, it consists of dry eyes and dry mouth, along with there is collagen disorder. Example, mostly rheumatoid arthritis or systemic lupus erythematosus. This is the secondary Sjogren syndrome. Next, moving on to etiology. Here the etiological lots of cause for the Sjogren syndrome. So first one is immunological findings, autoantibodies, immune complex, cell mediate immune response, natural killer cell activity, virological aspect, that is cytomegalovirus, and genetic aspect, HLA linked and non-HLA linked genes, and lymphoproliferative malignancy. It is very important, lymphoproliferative malignancy. So there is autoantibodies. The B cell hyperactivity may result from deficiency of suppressor T lymphocytes or B lymphocytes by producing autoantibodies against them. So why it is autoantibody? This is the reason. So next, moving on to clinical features. First one is the age and sex distribution. Age is middle age and sex is most commonly affect the females. And eyes, there is keratoconjunctivitis sicca, that is dry eyes, continuous irritation in the eyes. So severe lacrimal gland involvement, it leads to corneal ulceration and conjunctivitis. So here eye symptoms are very important, that is keratoconjunctivitis sicca. And next, moving on to next clinical feature is connective tissue disorder. Here, patients with secondary Sjogren syndrome usually present with rheumatoid arthritis. Here they consist of small joint and ulnar deviation of fingers and rheumatoid nodules. So these are the clinical features. And the next feature is dryness of the other organ. So there is dryness of the eye, there is dryness of the mouth, and connective tissue disorder, along with dryness of other organs also. That is dryness of the pharynx, larynx and nose, and lack of secretion in the respiratory tract. So these patients showing the Sjogren syndrome, having lacrimal gland and salivary gland swellings. Next, moving on to oral manifestation. First one is xerostomia. What is xerostomia? Dry mouth. So patient not complaint of dry mouth, but they complains about unpleasant taste, difficulty in eating food and soreness, and difficulty in controlling their denture, and angular stomatitis and denture stomatitis are present. And enlargement, here the unilateral or bilateral enlargement of the parotid gland. It is most commonly involved gland is parotid gland. The next gland is affected is submandibular gland. So in saliva, usually pooling of saliva in the floor of the mouth, it is very important. And mucosa is glassed, dry, and to form the wrinkles. So it produces a candidial infection mostly. So these are the oral manifestations. And also included, there is a speech, clinking quality of the speech. Because in speech, it is caused by the sticking of the tongue to the palate. That's why there is clicking quality in the speech. And next, moving on to tongue. Tongue is partial or complete depapillation, and dental caries mostly due to the accumulation of the plaque, and it is very severe, and acute bacterial sialadenitis. Sjogren syndrome is the most common underlying cause of acute bacterial sialadenitis in ambulated patients. The next is lymph nodes. Here the regional lymph nodes may be enlarged and tender. That may be painful. Painful lymph nodes is the main oral manifestations. So xerostomia and unilateral or bilateral enlargement of the parotid gland is very, very important. Next, moving on to radiographic features. First one is xylography. It is used for to detect the damage. And next is sylectasia. Sylectasia shows snowstorm appearance. So snowstorm appearance where it seen Sjogren syndrome. And atrophy of the ductal tree seen. And cherry blossom or fruit laden branchless tree. So here the important point we have noted that snowstorm appearance, cherry blossom appearance, and fruit laden branchless tree appearance. And salivary CT scanning, it is with technetium pertechnetate and salivary flow rate and labial gland abnormalities. It is used for salivary flow rate and labial gland abnormalities detection. And next, moving on to laboratory investigations. Here the first one is Rose Bengal staining test. So keratoconjunctivitis sicca is characterized by corneal keratotic lesion which stains pink when Rose Bengal dye is used. So Rose Bengal staining test. And next one is Schirmer test. Here it is used for reduced lacrimal flow rate is measured by this test. So reduced lacrimal flow rate is here measured, and a strip of filter paper is placed in between the eye and the eyelid to determine the degree of tears, and should be measured in millimeter. When it is less than 5 mm in 5 minutes, then it is positive for Sjogren syndrome. So it is very important test, Schirmer test, that is it is less than 5 mm in 5 minutes, it is positive for Sjogren syndrome. And the next test is salilometry. The salivary flow rate estimation is a sensitive indicator of salivary gland function. So salilometry is detect the salivary flow rate. So here if it is a Sjogren syndrome affected patient, then usually they have below 0.5 to 1 ml per minute salivary flow rate. If it is normal, then 1 to 1.5 ml per minute is normal. So salivary flow rate normal is 1 to 1.5 ml per minute. So next, moving on to the silochemistry. It is here the sodium chloride and phospholipids levels are high if the patient is Sjogren syndrome. So next, moving on to management. Here the management ocular lubricants, that is artificial tear coating, methacellulose and xerostomia. If it is have xerostomia, salivary substitutes are given. Oral hygiene maintenance is maintained, and salivary stimulants, that is bromhexine and pilocarpine and civimline are used. And surgery, if enlargement causing discomfort to the patient, then go for surgery. These are the management, mainly ocular lubricants and salivary stimulants, and oral hygiene maintenance is very important. So only maintenance phase is used. There is no absolute treatment for this condition, and we have to diagnose what the cause for this condition. And next, moving on to mucolysis diseases. It is associated with or differentiated from Sjogren syndrome. Mainly it is painless enlargement of the lacrimal and salivary gland, and it is a benign lymphoepithelial lesion involving parotid and lacrimal gland. So only parotid and lacrimal gland. There is no associated connective tissue disorders. Only these two present. This is